All right, good morning, everyone. My name is Andrew Niekamp. We're at SIR 2024, and today I'm here with Dr. Ramaswamy, who is a interventional radiologist at Community Health. So, Raj, I guess my first question for you is, how have you traditionally treated DVT? And then once ClotTriever came on, how did that change your approach to those patients?
So that's a fantastic question. So up until about 5 years ago or so, we were treating our DVT patients with catheter-directed lysis. Mm-hmm. And of course, what that involved was taking the patient, bringing him down for a procedure, accessing either IJ or the POPs, sticking these lysis catheters in or multi-sidal catheters.
Right.
And we do that as step one, send the patient up to the ICU. And then step two would be to bring him back down, and then we do any sort of combination of venograms and angioplasty and stent placements or whatever was needed.
Sure.
Then, of course, the technology improved.
Right.
So I'd say about 2 to 3 years ago,
Okay.
we started doing mechanical thrombectomy for these patients.
Right.
And it started off small, like a pilot program almost. We initially started with about 10 patients or so to see how these patients did with mechanical thrombectomy.
Sure.
And long story short, we found out very quickly that they were doing extremely well. Mm-hmm. And so within time, our practice converted completely from catheter-directed lysis to mechanical thrombectomy. And there's several reasons why we did that. Mm-hmm. Number one, patient outcomes were very good for mechanical thrombectomy. Number two, the use of hospital resources for us, it dramatically decreased.
Yeah, and I think that's something that's usually very understated and not appreciated is the minimization of resources and how that affects overall healthcare economics. But sorry, continue.
No, absolutely. And that's all around with everybody in the hospital. So our techs and nurses, we found that they were more happy to do the procedure with us. And then we found that the ICU nurses and the ICU team didn't have to manage our DVT patients anymore.
Sure.
Watch those pesky drips and things like that.
Exactly.
And so at this point, I would say that in our practice, we probably have done about 250 cases.
Wow.
I myself have done about 120 to 150 of those. I'm not exactly sure what that number is, but that number continues to grow.
Sure.
And such that we don't have lysis catheters on our shelves anymore.
Yeah.
And we're solely a mechanical thrombectomy practice now.
Right.
And ClotTriever is to thank for that.
Yeah. So I think you brought up a really good point with the ease of use and the single session, which I think is huge. I mean, the reduction in hospital resources is extremely important, and the ability to have bloodless thrombectomy, which is what ClotTriever provides, is very, very pivotal and allows us to treat a patient population which otherwise would have been at very high risk. We have a large Jehovah's Witness population in Miami, so I know that for us, it allowed us to really treat those patients more aggressively, knowing that they weren't going to experience any blood loss. But we're both physicians, and we know what we really care about is the actual outcomes of the patient. So when you have a patient that comes in and has a DVT, how do you kind of figure out what your treatment timeline is? Do you trial anticoagulation first? How do you decide inpatient versus outpatient? What's kind of your algorithm that you've come up with?
Yeah, that's a fantastic question. So as far as timeliness, we want to try to treat these clots as quick as possible, because what we have found in our practices and nationally, what we know about clots is that if you let them sit for a longer period of time, they become subacute or chronic,
right,
and it becomes a lot harder to pull it out.
For sure.
So with that being said, you have to also factor into consideration hospital resources. Are there open beds, for example?
Yeah.
So typically these patients come in through the ER, and what will happen is if we have a bed available in the hospital for the patient to stay, we'll bring that patient into the IR lab the same day or the next day, and we'll treat as an inpatient.
Sure.
And that's for patients that are, if we have bed availability and if they have iliofemoral DVT. Okay. So if we know that that's the case, then we'll treat them as an inpatient.
Okay.
If you have a different scenario, let's just say there aren't beds in the hospital or the clot isn't as extensive, such as iliofemoral DVT, what we do is we ask the ER to put the patient on anticoagulation, a DOAC such as Eliquis.
Okay.
And then they'll discharge the patient with a clinic follow-up to interventional radiology.
Okay.
And within a day, we will call these patients and have a video visit, and then we'll schedule them if they meet certain criteria for treatment.
Great.
And we'll bring these patients in as an outpatient. We'll treat them single session, and we discharge them home the same day usually.
Okay. That's great. Yeah. I think it's really important, and I think it's really admirable and encouraging that you've come up with this system to try to make sure that none of these patients fall through the cracks, because as we know, this disease process is extremely undertreated and many, many unmet needs, and this patient population has been widely ignored for so long. So having these algorithms in place like you do to make sure none of them fall through the cracks is extremely important.
Yeah, I agree with that. And It took a while to get there.
Yeah.
But education to the emergency department
Right.
is extremely important.
I couldn't agree more. Yeah.
And so when somebody's building a practice, what I advise them to do is I say, hey, you get that patient in and treat that patient as quick as you can, because if you leave it to the emergency department initially when you're building a practice, they'll place the patients on anticoagulation and send them home.
Right.
And you'll never see them again, or there's
Exactly.
no follow-up. So initially when you're building a practice, get all these patients in, and then once you establish that algorithm with the ER, then you can have these different treatment pathways that are a little more complex, per se. And I would say at this point, 40% of our DVTs are now outpatient procedures.
Oh, wow. Okay.
So we do quite a bit outpatient.
Yeah.
We'll keep the patient for 4 hours post-procedure to make sure there's no complication,
Sure.
which there typically is not, and then we send them home. So
That's great.
Yeah.
That's great. Well, thank you so much for your time today. I really enjoyed talking to you, and I hope that we get together and catch up at SIR as the
Absolutely.
week goes on. All right.
Thank you for the time. I appreciate it.